Two people can have the same skin cancer name and need very different treatment because risk, anatomy, margins, health, and goals change the problem. Wait, let me just stop you right there. If they both have basal cell carcinoma, why doesn't a cancer diagnosis just result in a standard removal process for everyone?
Well, because a visually small tumor can actually carry a very large margin problem. Look at patient A. They've got a superficial tumor right on their trunk, while patient B has a recurrent infiltrative tumor on a highly constrained area, the nose. So the exact biopsy results, the specific patterns of extension, and the future reconstruction at stake dictate entirely different treatment paths.
This explainer was written and edited by Dr. Thomas Hocker, a triple board-certified Harvard and Mayo Clinic-trained dermatologist, Mohs surgeon, and dermatopathologist. The main goal here is finding the least treatment that reliably solves the actual cancer problem. We aren't looking for the least treatment in every single case, and definitely not the most intensive treatment by default. Which brings us to Section 1, Risk versus Staging, different tools for different jobs. We've got two fundamental tools here, and they do completely different jobs in the clinical pathway. First up, risk stratification. This estimates how a tumor is likely to behave. Will it recur locally? Is it aggressive? So, understanding patient A's risk, for instance, helps us select their specific local treatment. Staging, on the other hand, estimates how far the disease has actually extended. Has it reached the lymph nodes? This guides our prognosis, our imaging, and systemic management. While these two concepts definitely overlap, it is absolutely vital to remember that they are not interchangeable. Before we get too deep into the weeds here, I'm looking at Breslow thickness under melanoma. What does that actually mean for our patients?
Yeah, I'm really glad you asked that because different skin cancers require vastly different sets of information. Let's look at basal cell carcinoma, or BCC. Distance spread is incredibly rare there. The dominant treatment problem is local extension. We want to prevent destructive recurrence, and we want to preserve tissue. But if you move over to cutaneous squamous cell carcinoma, or CSCC, things change. Now, along with local control, we're looking at variables like depth and perineural invasion, which can introduce nodal and disease-specific risks. And then there's melanoma. Here, the key pathology input completely shifts. We are totally focused on microstaging, specifically Breslow thickness, which is the actual microscopic depth of the tumor, and ulceration. You literally cannot import a margin method designed for BCC into melanoma without fully accounting for these specific permanent section microstaging needs.
All right, let's move to Section 2, the margin problem. How much is enough? You really cannot compare any treatments fairly without understanding exactly how the surgical margins are going to be assessed. In a standard excision, the tumor is removed with a planned clinical margin, and then the specimen is evaluated using representative vertical sections. Think of it kind of like taking slices from a loaf of bread to see if there are any raisins inside. It's a highly effective approach for many well-defined tumors, but it doesn't examine every single millimeter of the edge. Now, most surgery works differently. The tissue is processed so the peripheral and deep margins can be examined as a continuous end-face surface, meaning we look flat at the entire bottom and the edges under the microscope. So instead of just looking at a few slices of the bread, you are examining the entire crust. Here's how that Mohs feedback loop functions in real time. First, you map the excise layer. Second, you process it on face. Third, you examine those continuous margins. And fourth, and this is the absolute key part, you remove additional tissue only exactly where the tumor remains. So the crucial point to take away is that complete margin assessment isn't just more surgery, it's actually more information during the surgery, which allows you to preserve healthy, uninvolved tissue. Okay, let's pause right here for a second, because if Mohs checks 100% of the margins and saves healthy tissue, why isn't it just the default for absolutely everyone? Is Mohs always the best operation?
That is exactly the question we need to answer. And the short answer is no. Mohs is not always the best operation for every patient. Let's look at why.
In the best randomized evidence we have for facial BCC, evaluated at a full 10-year follow-up, Mohs demonstrated a statistically significant recurrence advantage, specifically for recurrent facial BCC. But I want you to notice that specific qualifier. Patient selection and tumor mix heavily influence these outcomes. There is no single universal cure rate that applies to every diagnosis, every tumor, and every single patient. Mohs is actually most compelling when you're dealing with high-stakes anatomy, just like patient B's recurrent tumor on the nose, where tissue preservation directly changes function. It's also vital for recurrent tumors, those in previously irradiated skin, tumors with aggressive or poorly defined growth, or when there's perineural involvement, which is where the cancer tracks along nerves, making extension really hard to predict. Finally, it's totally essential when you need absolute confirmation of clearance before beginning a major facial reconstruction. But if those factors aren't present, standard excision remains an excellent, guideline-appropriate treatment. Remember patient A? Their primary superficial tumor on the trunk is a perfect example of where appropriate margins can be safely removed without any unacceptable functional cost. Standard excision is also the appropriate operation for most localized invasive melanomas, relying heavily on those Breslow thickness margins we discussed earlier. As long as the pathology plan matches the biological risk, standard excision is a superb choice. Which brings us to Section 3, non-surgical alternatives. When do they fit? I hear this all the time, though. What if a patient, say patient A, just wants to use a cream to avoid surgery entirely?
Yeah, it's a really common preference. And topical therapies like prescription creams can be highly effective, but only for carefully selected superficial BCC or SCC in situ. They work by treating a wider skin field. However, this is the vital trade-off. They yield absolutely no margin specimen. Because you cannot confirm microscopic clearance, these creams are not an interchangeable substitute for margin-controlled surgery in recurrent, infiltrative, or higher-risk disease.
And that exact same boundary applies to radiation therapy. Radiation is absolutely a legitimate option for selected patients who cannot safely undergo surgery or who make a fully informed preference to decline it. But it solves the margin problem differently. It treats the tumor and a planned surrounding field right in place. There is no X-size specimen proving microscopic clearance. Success has to be assessed clinically over time, and it comes with a completely different burden, including late tissue effects like pigment change, atrophy, and fibrosis. Let's wrap up with Section 4, timing and next steps. How urgent is treatment? Most skin cancers obviously require timely treatment, but that urgency is totally risk-calibrated. If there's rapid growth, neurologic symptoms like numbness, or highly aggressive pathology, the timeline is accelerated to a matter of days. However, a smart, short plan interval used to obtain deeper pathology, coordinate staging, or assemble the right clinical team for a low-risk tumor is perfectly reasonable. What is dangerous is an unexplained, indefinite delay. For biologically aggressive cancers, progression during a delay can fundamentally change staging and severely limit your treatment options. Ultimately, treatment selection comes down to this framework of shared decision-making. But let's be super clear here. Shared decision-making does not mean presenting every single option as equally effective for every tumor. That's a false equivalence. It means aligning medically reasonable choices with the patient's specific health goals, discussing the exact margin assessment type, the expected functional consequences, and how the patient's personal priorities really change the balance of care. Dr. Hocker created Skin Trust to provide free, evidence-based dermatology education and help patients and clinicians make clearer decisions together. We really invite you to read the complete, deeply sourced article at Skin Trust, and most importantly, use this framework to discuss your individual decisions with your treating clinician. But what happens when the pathology report comes back with terms you just don't understand? In our next Skin Trust Explainer, we decode the biopsy report line by line. Until then, remember, the best treatment is always the one that solves your exact problem.